Welcome to this session on the European Health Union in a Danish setting as part of the Danish Policy Festival Folkemødet. It's my great pleasure to welcome a great team of speakers talking about the implications of, well, cross-border collaboration on health, and especially today with a focus on the European Health Union as a case on that. We've three great speakers in the virtual room. You'll be noticing that we're not actually sitting on the island of Bornholm. It would have been nice, especially for you, Anniek. I suppose you don't get there that often. But of course, what you're looking at is Anniek de Ruijter from the Amsterdam Law School, Amsterdam University, Maja Kluger Dionigi of the Tænketanken Europa, and then Bogi Eliasen of the Copenhagen Institute for Future Studies. And my name is Lars Münter of the Danish Committee for Health Education, and also a proud member of the Nordic Health 2030 movement that's organizing these sessions across the Nordics. The Nordic Health 2030 movement is, of course, set in place to talk about working to improve health towards the future and across borders. So it makes sense to talk about the health in Europe, because what is the European Union really about? If not perhaps health, security at least, we know that, safety, prosperity, a lot of positive words. Today, though, we are going to talk about health and the implications also about the European Health Union. What does it mean for Europe? What does it mean for Denmark? What does it mean for the Nordics? There's a lot of questions and a lot of things to dive into. But first off, it's my pleasure to give the floor to Anniek de Ruijter and a brief introduction and sort of a deeper dive into what is that European Health Union. Please, Anniek.
So thank you very much, Lars, and I'm very happy to be here, and I want to thank the organizers as well. So yeah, you asked exactly the question that we were asking this summer when this idea started evolving of a European Health Union. Is what is it? It's a great term, but in Europe there's a tendency to call all kinds of things a union. But of course, what matters is what happens on the ground and what actual laws and regulations and policies can flow from this. So we created a manifesto where we basically outline, and I would invite all the listeners also to check out our manifesto on the website, the Manifesto for a European Health Union, where we basically listed all the elements that we think should be part of a European Health Union. And that is much more than what the European Commission has proposed should be part of a European Health Union. Because after COVID, or in the midst of COVID, a lot of the proposals and the ideas that came out of how could the EU be of added benefit to what is already going on in health policy and health lawmaking in the member states was to do with emergencies, coordinating and exchanging and regulating aspects that have to do with health emergencies. But as we all agree, health resilience is about a lot more than emergencies. It's about a healthy population. It's about access to healthcare. It's about inequalities, health equity, etc. So it's about a lot more than just preparing for the next emergency. So that is basically what that manifesto is about, that if we want for the EU to have an added benefit to our health systems and our public health systems, we should look at the broader picture. And for me as a lawyer, that also included thinking about the current way EU law and regulation is shaped and has taken shape in the past, and what we would want for that in the future. So I think one of the important things to keep in mind that just moving power from the member state level to the EU level through law, through delegation, is not in and of itself an improvement. There are areas that can be best regulated at national or even at local level. And then there's some areas in health that should be where there can be a real added benefit at doing it at EU level. I think one of the best examples is the reference networks, where you have hospitals that specialize in rare diseases, where you can have the added benefit of the economy of scale and the knowledge, the scaling up all the knowledge that is there on a rare disease. So there, in those types of areas, the EU can have an added benefit. Another example is the joint procurement of emergency vaccines, where you have the added benefit of creating a better negotiating position at EU level, and where you can create a bigger stockpile. And you can create a better spread of all the different vaccines that you purchase, so that you have all the vaccines available. But joint procurement of antibiotics, for instance, would also be a clear added benefit that we're not doing right now. So there are some areas where there is this real potential to do stuff at EU level that we're not yet doing. And so when I think about what would that mean for law, I think one of the important things is what hasn't happened enough in the past. And I think what we now should at least try to, take this window of opportunity that COVID has shown us, all these gaps of how we could work together better, is to think about so health policy and law is something that is very much at national level regulated by the professional community, by the medical community, by the public health community, because it's a very specialized field. So you need to have that knowledge in order to make the laws. And also it helps create legitimacy, and so it carries over in the quality of the legislation that is made. Now, at EU level, because there's very limited legislative power to create laws specifically with the objective of health, there is that health community is not very much connected in the legislative process. In the EU, oftentimes health law, like the rare diseases network, for instance, that the directive that rare disease network, the reference networks of hospitals is based on, is internal market law. So when those laws are made, a lot of the health community that is connected to the national ministries of health are not involved. So a lot of health lawmaking in the EU is done either in the internal market or in agriculture or in enterprise, where the health community is not connected, because those laws are made with the involvement of the finance ministries, or even the agriculture or the social ministries that are not the same as the health ministries at national level. And so if we would improve the competence in the treaty of the EU, where we would have a shared competence in health that is more holistic, we would also change the legislative process to include the health ministries more, which then would help also to have these professional communities involved. And so I think that would really improve the quality of the legislation. It would also improve the political debate on, can the EU have an added benefit with this legislation or not? And that might mean that we see less coming from Europe, that we see less health law coming from Europe, because in some areas you might not want the EU law could be an elephant in sort of this very finely tuned national health systems. So this kind of carefulness, I think, can be much more better evolve if we would have a real health community involved in creating health law at EU level. So that is really one of the major things that we're also trying to push for with this initiative of a European Health Union, where the discussion indeed just should be more holistic, broader, and much more beyond health emergencies, but really focusing on health resilience.
A great point, and two of the force through some of the key points that this has relevance for other people. And one would say, perhaps with a smile, that at least that made finance ministers to think about health once in a while. But as another point here, So yes, it's also saying perhaps that one of the elements of not having the European Health Union makes some in the medical community feel left out, that they miss out from a political influence also, maybe a lack of a sense of community. I mean, of course, with the ERN, people are working together and collaborating, but if they feel they don't have a political voice, it makes them obviously turn to national entities and not find these also sort of common solutions. Is that a sort of a democratic problem as well?
Yes, I think a lot of health law and health policy making in the EU is either done through soft, informal mechanisms, a lot of pushing, a lot of cooperation, where, you know, the European Parliament is usually not involved. So it also leaves out sort of the civil society aspect of and the democratic legitimacy that is needed in this case. But also, I think that as soon as health actors see that whatever goes on in the EU matters because their national health ministries are involved, where all the links and the ties and the networks are very much connected, as we all know, which that would also engage them at EU level much more. And I think when the EU makes health law and policy, it should be done with the objective of health in mind, human health, because the EU can be about health. It's not only about the internal market. And the court has said so as well, that it is important that the internal market is not all that the EU is about, but then it should also have the constitutional setup to create legitimate laws and policy to do so.
It's been a debate for a number of years in Denmark. What added value, if you will, that the inclusion of lawyers and sort of bean counters has had in the health industry, but this is certainly a vital point where you see that law actually makes a difference for health too. I wonder perhaps if we should move on. I think maybe that there would be a question or two on the ERN, especially when we've had in the European Union a member leaving us that was a very active partner in the ERN normally. What would you, and also for you, I guess, Anniek, what's your take on that? Is it the ERN? Maybe should we move it, I guess, outside the European Union, and perhaps is this something that should actually be part of a global solution, going from rare to just uncommon diseases, if you will?
Yes, I think there's really nothing stopping the health community there's no legal barrier to creating networks, to ensuring that patients are sent or at least put in touch with the places and the doctors that know most about their, and this is also a simple aspect of globalization and the internet and the technological possibilities that are there. But in the EU, of course, for a long time, we have seen that, I'm sorry, I'm going to close my door, hold on.
Always modern meetings.
No, and in the EU, of course, we have seen that it was difficult for patients to access cross-border healthcare, but there is that directive right now. There is an increasing sort of, cross-border healthcare has always actually been for the few border people working and living on the borders of and for the people that really need access to these types of reference hospitals, etc. So a lot of these things are not the legal barriers, I think, are not the most important. The most important here is more the policy making and what is being done to stimulate these types of developments. And honestly, I think if there are the medical connections in the networks within the medical community between the UK and some of these hospitals in the rest of Europe, they will remain. I would be surprised if medical professionals would let something like Brexit stand in the way of that.
I prefer not to comment, perhaps, at this point. Yeah, Brexit is a strange force in life, I suppose. But talking about then the impact in various communities, let's move on to involve also Maja from the think tank Europe, because as Anniek very rightly pointed out here, this has impact at a local level. This means something for people at a national level, who they look to, how they organize, how they feel their voice represented, and so health in Denmark, and health as a part of European collaboration, Maja. How does this reflect? What would the European Health Union mean if we think, although we're doing it in English, about a Danish setting?
Yes, I'm going to focus the answer on two perspectives. So first of all, I'm just going to take the temperature on the public and political mood in Denmark towards strengthening the European Health Union, or creating it. And then secondly, I'm going to turn to the example of vaccine, both in terms of the whole vaccine strategy by the Commission, but also what do we do in the future in research and development and ramping up production from the Danish perspective. So first of all, starting with the Danish views on the European Health Union, using the word union is always something that has created unease in Denmark. And as Anniek rightly mentioned, you have a lot of union developments at the EU level: banking union, capital union, energy union, now a health union. And the reason why it creates unease in Denmark, as well as in other member states, is that it's generally seen as a threat to national competences. And of course, we know that calling something a union doesn't make it a union, particularly not in the health area as it stands now. But you always had this uneasiness. And looking at the discussion about should we have a treaty change, should we see more powers to the EU in the health area, that is a no-go area for most of the Danish parties. So we currently have 11 parties in the Danish parliament. One, maybe two parties would agree that that is a good idea: the Social Liberals, Radikale Venstre, and perhaps the Christian Democrats. But otherwise, there's no appetite for giving Brussels more powers. However, there is also a clear realization among the public, and as well as among the politicians, that inaction is not an option. But the usual spiel you have from the Danish government to the Danish parliament on health policies in the EU is that they always say we are positive towards strengthening EU cooperation in health security. So they frame it as security policy rather than health policy. But you always have the usual disclaimer in all of the documents I've been following on EU public health, is that the EU needs to respect the division of competences between member states and the EU. So it needs to be a member state competence. And if we look more specifically, without going too much into the nitty-gritty, but if we look more specifically on some of the proposals you have in the Health Union package, with the strengthening of the existing health agencies, such as the ECDC, the European Centre for Disease Prevention, and what's the last one? European Centre for Disease Prevention and is it control?
Control.
Yeah, control. Yeah, control. The government, as well as the majority of parties in the Danish parliament, are skeptical towards giving the ECDC the right to conduct regular evaluations of national crisis preparedness plans. They are also not particularly eager on the proposal to have an obligation for member states to make action plans in order to address the recommendations coming from the ECDC. Because even though this is not ceding formal competences to the EU, it's somehow seen as a way of meddling with national competence. We don't want to be told what to do. So there is this, slight skepticism, even though inaction is not an option. And then briefly just turning to, so what is the public mood among citizens? We have the latest Eurobarometer survey from the European Parliament, particularly focusing on the pandemic. And if we look what Danes think compared to the rest of Europe, in this survey that was conducted in April this year, 81% of Danes are overall satisfied or very satisfied with the measures taken to fight coronavirus pandemic by the EU, compared to 48% in across the EU. So that's obviously quite high. 59% of the Danish respondents agree that the EU should gain more competences to deal with crises such as the COVID-19 pandemic, compared with 74% across the EU. However, no survey has until to date asked the question if EU citizens would like to cede powers to Brussels, or if they would like a treaty change, and possibly the answers would be very different from the Danish respondents if that was a question being asked. So overall, we should not have any inaction. We should strengthen European health collaboration, but we want to maintain our national competences in the area, and we don't want the EU to threaten that. So that's sort of taking the temperature at the moment. Of course, it may change as we negotiate these packages over the next couple of months. Right, turning to the second aspect of my presentation, vaccines. Looking back at the whole vaccine strategy by the EU, as Anniek also mentioned, there's been strong support from all parties, as well as the public in Denmark, that the EU should take the lead in joint vaccine procurement. And although, I mean, counterfactual history writing is always hard, there's a clear realization that a small country like Denmark would have struggled to secure enough vaccines had it not been for the Commission taking the lead. Had we not done this together, we would most likely have had less favorable contracts and with fewer vaccine developers. And that's also something that the Prime Minister has been saying again and again when the Commission was criticized for its vaccine strategy. She was saying, you know, we could not have done this alone. We would have been in a much worse situation. So there, the Danish perspective is that we need the EU track for joint vaccine procurement. However, the mood seems to be very different when it comes to what do we do in the future to ramp up vaccine production. Are we willing to pay for more joint research and development in vaccines and antibiotics in the future? Here it's a little more uncertain how Europhilic the Danish parliament is, and as well as the Danish population. And I say this because in April this year, the Danish Prime Minister announced that she wanted to have Danish vaccine production in Denmark in order to secure enough vaccines for Denmark by 2022. And for a long time, and it still is, a bit uncertain if she wants Danish vaccine production only, or if she wants this to be part of a wider European supply chain. I think she's aiming for the latter, but in the press, she's phrasing it as if it should be national vaccine production. And her proposal has been met with concern from the life science industry in Denmark, who in unison say that Denmark is too small a market to have a profitable vaccine production. Global supply chains are too complex. One country can only contribute to part of the production, but not all. We need European collaboration in this area. And there's also realization that production in Denmark would hinge upon a licensing agreement with vaccine developers. And Bavarian Nordic has already asked some of the big vaccine makers, Pfizer and Moderna, if they would offer to help them, but their offer has been turned down because they're too busy at the moment and it's too complex and you can't just transfer knowledge on a short term like this. So it quickly sort of became apparent, the response to the Prime Minister's proposal for Danish vaccine production, that you need a strong international collaboration on research and development and production in order to have the required expertise to develop vaccines on a grand scale in the future. And this then lastly leads me on to the last point, namely that the EU needs a unified approach to vaccine research and development, or also in antibiotics, not only vaccines, as Anniek mentioned, and also a proper investment strategy. And this is where the European Health Union comes in, because the EU is increasingly, or has since the summer, looked towards the US to see why is it that the US has been so successful in the vaccine rollout until now. I mean, now you have slight skepticism, so we are sort of rolling out to the same extent in the EU as they do in the US now, but they have vaccinated way many more people than we have in Europe. And what the EU is missing is that we do not have a unified entity that can invest in vaccine antibiotic research and development early on. And that has slowed down the initial availability of vaccines in Europe. So if we look at the statistics, and I will turn back to the Danish view in a moment, but if we look at the statistics, the EU with its member states is the world's largest purchaser of COVID-19 vaccines, followed by the US. But the US is the largest upfront investor in research and development, followed by the EU. And the EU has a much slower and less integrated approach than the US when it comes to financial burden sharing between member states in terms of investing in research and development, where you have Germany topping the chart. And we also have a much less integrated approach when it comes to linking research and development subsidies to production and procurement. So this is why the Commission is proposing later this year to have a new EU agency called HERA, a Health Emergency Preparedness and Responsive Authority, or what Ursula von der Leyen initially called a European BARDA in her union speech in September. BARDA is the US Biomedical Advanced Research and Development Authority, and is one of the recipes for why the US had a much quicker vaccine rollout, because BARDA, since it was established in 2006, has invested on a large scale in vaccine research and development through public and private partnership, and have combined this with advanced purchase agreements with the companies that they have supported. The question is, how are we going to pay for this? Because the ambition of HERA at the moment is not in sync with the EU's budget. So if we look at how much BARDA costs in peacetime, so when there's no crisis, BARDA generally gets about $1.6 billion per year. But the crucial point is that the US state can top this up during a crisis. So in 2020, BARDA got around $18 billion extra to speed up the development and production of COVID-19 vaccines. And in comparison, the EU spent 2.7 billion euros from its emergency support instrument to finance some of the upfront costs that vaccine producers have. And they also obviously entered into advanced purchase agreement, but on a much smaller scale. So if we want something like BARDA in the future, and the Commission 2 days ago, when it came forward with its lessons learned communication, said that we want HERA to be operational in 2022. But if we look at the long-term current budget of 7 years, that's completely set in stone as it stands now. It does not make the EU very agile to find the financing. It will be very controversial to take money from existing programs. And if we look at Denmark, Denmark last summer, was when the budget was being negotiated, was part of the Frugal Four, and was one of the reasons why the health budget was slashed compared to the Commission's proposal. So would a country like Denmark be willing to put more money into the European BARDA, HERA, in order to have something similar to the US setup? So perhaps even though inaction is not an option, BARDA will get a more restricted mandate that would reflect the financial means that member states, including Denmark, are willing to make available. And a last sentence, and then I stop here on a very final note. If we assume that HERA, this new agency, in peacetime, when there's no crisis, is going to cost the same as BARDA, so that is $1.6 billion per year. And if we assume that member states pay according to their population size, the annual Danish contribution is going to be 128 million Danish crowns. And to put this into perspective, this is equivalent to what the Danish state is now currently paying for 2 to 3 days of COVID-19 testing. Thank you.
Putting things into perspective, Maja. It's a fascinating thing, actually, also the fact about, the idea is that if you collaborate on a larger scale, you'll find better solutions than what you can find yourself. But on the other hand, you don't want anyone to find better solutions that they have to tell you how to do it. That's a dilemma, or certainly a mystery how you can wrap your mind around that in that sense. I'm sometimes reminded by the basic fact of the Good Friday Agreement, where the key element to it was that they redefined what it meant actually to have a national understanding. In that sense, before the Good Friday Agreement, you could either choose to be Irish or British, and they were stuck in that dilemma of only thinking of themselves as either or. And the Good Friday Agreement then said the idea that you could be British or Irish, or you could be both. And in this case, perhaps also introducing gray zones. I mean, why are we only talking about this either as European or as national? In a way, it's either or, and maybe that's part of the path forward. I think we should go back to this discussion just after we also get the input from you, Bogi.
Yes.
Is this then clearly something that we are fixing right now, or what's the path we're heading towards, Bogi?
Yes. First, thank you very much for this two very, very interesting approaches and oversights and insights to it. So to me, there are some crucial cornerstones to think about. Our basis of working, and one of the reasons I've been so supportive and happy with this idea of the European Health Union is that the way we're thinking health systems today is not sustainable, is never going to be sustainable. The way we are constructing both the budget, how we use technology, when we set in with working with health, cannot work as we hope it does. So that's the one side of it. Let me just go a little bit into it. So we have practically a sick system, not a health system. We do not invest in order to keep healthy, but we do invest in order to treat, but treat very late. It's not early intervention, it's not early detection. So this is one part, going back to the way that Maja was saying, also on cost and comparing to how much does it actually cost to do testing. But this should be a mindset of a much larger scale. So the challenge we have in modern health system is that the disease burden in a lifespan for each individual is growing, and is growing fairly fast. So we have gained 10 years, the last 30 years on average in Northern Europe at least. Half of them are with extra disease burden. There is no more productivity. So this comes as an extra cost to society. On top on the big question, which is the dignity. So how can we have a focus on quality of life and well-being during the lifespan? It's very hard to work with when we work with annual or 4 or 5 year budgets, which the political cycle does today, because most of the technology which enables us to do new things only pays off if you think in decades or lifespans. So how can we begin to think differently in this? So health as an investment, not health budget as a cost. The other side here, so I've followed the European reference network since the start, and I think that's a very, very good experiment on what health will look like. So what technology gives us is precise insights into what is happening with disease. What that means is that most diseases will become like rare diseases. One size fits all is dead if we want to use it. But there are some other parts of this. So the population we need to work with in order to make sense of the knowledge, of the wisdom, is not in a country in Europe. No country is big enough for that. So we need to share the data between the countries. We have worked and invested in the European Union, for instance, in the digital health data space. Probably 90% of it is on anonymized data, which is fine for some research, but unusable for clinical use. So there are some concepts to work with. What is it really we want with this? To me, why is it so important? Health is the most fundamental pillar of a just, a fair, and a society with dignity. That's as simple as it is to me. And this is what I see in working with a health union. If that means that we need to have a new European treaty or we need to do amendments, that doesn't really matter to me in that part. It's more, can we get the focus on that we want to provide health and not the additions into different parts. And health is much more than what happens in the hospital. So for instance, in data, we normally put it forward as data that provides health. It's not necessarily health data. So there are many aspects where I think the European Union really can go in. And we have, if we look at the mood in the European Union amongst the citizens, we are not so keen on the Silicon Valley model of working with data that becomes personal, or the Chinese model with data that becomes personal, but we are not putting our act together and creating what is it then that we want for a health and healthy society in that way. So and the gray zone, yes, I think there are gray zones to deal with. There are gray zones to accept, and we do also need to admit that what we want with health is a new paradigm. And a new paradigm requires that we need to leave some of the things that we can't grasp as opposing things today. For instance, the old privacy is never going to come back. So if we want privacy, okay, then we need to build it in a different way, right? If we want to work with data, then let us choose that we have data sharing so we can utilize the power of the data and not put it into silos which can't be shared, because why produce it if you can't use it? So the question to me is less about exactly which frames, much more about why do we want this and why is this important? And the other part is that I only see one stakeholder, one actor that can focus on what Lars and me also work a lot on. How do we give health to the world? So what we call the 1090. Today, all health development is to the richest 10% of the world. How can we integrate into workways so this covers the other 90%? Because our health, our resilience against pandemics will not be there before we do that. So with that, I think I will just let free so we can have a discussion.
Well, thank you very much, Bogi. And indeed, one of the basic points here is that when you invest in certain stuff, and it goes back to what you're talking about, Maja, and the example of how much we use on testing as compared to what it actually costs in other ways. There's a basic argument here that also has something to do with money, costs. Is it really when we're worrying about giving someone the competency, but surely there's a huge economic upside to this as well. It's simply bad. Well, I don't think the right word is business. It's bad business, but it's not really a very viable economic model to keep on having these different silos, national silos on health. Is it? As a rhetorical question almost, but Anniek?
Well, I think that goes both ways. So clearly there are economies of scale that where the EU can have, like if you look at the joint procurement of vaccines, for instance, or investing in research and development. Clearly, you should do these things at a higher level than the national level, particularly because some of those issues, I mean, the lack of new antibiotics, just to come up with that example again, is clearly something that we're going to all be faced with. So there's clearly economies of scale, but there's an important reason why you see this national resistance against more power in the EU. It's because we pay taxes directly to our government, and that creates a connection between me as a citizen and the state. And then the state provides for me access to healthcare. So there's political capital there. There's also my cultural connection to the state and the monies that are being paid. And also, if the EU would create laws and policies that infringe on that relationship or make decisions, for instance, what is in the basket of care, that that type of law could have a much different impact in some member states in the South, in the West, in the East. Which I think is a very good reason not to adopt any laws that do that at EU level. And at least right now, the differences between health systems, the way they're organized, the funding that is available, is so vastly different that taking an EU or adopting an EU law could have very detrimental effect, depending on the way that it would impact. And it's not like we know from research very well what the impact of a law is on health. So the causal relationship between law and policy and the actual outcome on the ground is not very steady, like we know exactly what we do when we adopt a law. We don't. So I think rightfully, especially also when it comes to money, you don't want to have the EU take all kinds of measures. But the question is, how do you legally design the way to do that, to ensure that because it's not like these laws can currently not be adopted at EU level, and they have in the past. It's just that you empower your colleagues that are working on finances or that are working on agriculture to make those decisions for you. So any national parliamentary member that says we should not give the EU competence in the field of health because of this very reason, which I think is a very good reason, is basically just empowering a different ministry, because the EU is nothing more than its member states. It's not like the EU is anything. So the member states together, so anything that is done at national is part of the EU. So it's that I think is sort of misunderstood. It's not like when you don't give the EU power in the field of health that the EU doesn't have any ability to make laws that will impact on that relationship that health law and policy creates between the citizen and the state, or on the actual, sometimes even on the redistribution of funds. It's just like, what is the legislative objective behind making those types of choices? Is that curbing spending, like we've seen in the European semester, that some member states had to stop spending money on creating a resilient health system? Those decisions were made by finance people. They were not made by health policy people and health ministries. So it's just like, what community of experts and what community of and what type of objectives do you put in the lead? And so I think it's very misunderstood to think that you can stop the Europeanization of health systems or health policies by not giving the EU the competence to do so. And that is maybe a mistake on a constitutional level in the EU, that is not possible to do. But politics and policy making always precede law, right? I mean, so you just have to look at, you can't use law in that way. It's maybe also just a misconception about what law can do. But anyway, so these are my my comments.
In sort of indirectly saying that we're just simply shooting ourselves in the foot at this stage. But also, though, Maja, a very one thing that we're useful and used to, coming back to you in a short while, Bogi, is that we are used to doing this completely within food production, and certainly food is something that we use to maintain our health. Last time I remember, at least our joy sometimes. But how when it is so normalized to do this within food, why is it so hard perhaps to accept within health? We eat every day. We only use health services. Well, not every day, at least. Most of us. Maja?
You're asking me?
Yes. So what's the? Is this a special Danish misconception? Would you say?
Well, I agree very much with what Anniek has just said about, we paid our taxes to the health system here, so we want the health system here to be accountable to us and deal with it. But I think there are two elements to this debate on what the EU should do and can do without making a treaty change, because no one except Angela Merkel and Macron is floating the ideas of having a treaty change, at least when you look at the leaders of the European countries. But there are two aspects. So one aspect is the money part. Are we willing to beef up the budget, to invest more and pool our sources when it comes to research and development in antibiotics and in vaccines in the future? And if we just go 15 years back, the EU budget did not have this straitjacket as it has today. It had a much larger jacket. And when you had the veterinary crisis, it was possible to take money from the reserve to address this crisis. But we don't have anything on this when it comes to human health, which is a bit bizarre. We got it in the veterinary sector, but not in human health. So there's a question to be had, which also shows that health is not only just about health in a silo, but it branches into so many different areas. So in this case, the budgetary area, do we need to completely rethink the way the budget is working now in order to be able to react quickly when we have a crisis, and obviously have this long-term funding and setup that we can rely on when we have a crisis, and have an extra reserve that we can draw on, as you have in case of the US BARDA. So that's one thing, that's the money side. And it's still to be seen what the mood is for increasing the investment or for beefing up the budget of HERA. We don't know yet how member states are positioning themselves. But I think, as Anniek mentioned in the beginning, there is a window of opportunity. And if there's something that this corona crisis pandemic has really shown the electorate, is how costly it is to close your economies and have this lockdown. How many people the state in at least some countries had to support through salary compensation. I mean, it's been an extremely costly affair. So perhaps now is the moment that people can see that it really makes sense to invest in order to avoid having this sudden cost when a crisis appears. So perhaps this is a moment for change. Then there's the other question, which go back to what Bogi talked about in terms of good data. And also, how do you make the existing setup work? So here I'm particularly thinking about the ECDC, where one of the main problems is that member states have not fulfilled their reporting obligations. I mean, the ECDC did not have the overview of what is actually going on in the member states. Member states did neither not report, they reported too late. They reported in a non-standardized way in all different matters. Some member states, they would, send off 2 pages and say, this is our preparedness plan. We all prepared, it's all good. So that's a problem that the Commission is trying to address now. But here again, as Anniek has mentioned in many of her publications, it's not only about health. Here the question is also about, well, what can we actually do within the current general data protection rules? I'm not an expert on data protection, but I know that the collection and sharing of European citizens' health data and patient information is not so easy within the current GDPR rules. So do we need to change them, and how should they be changed? What about healthcare system data? They're not standardized at the moment. Is that something the EU should standardize? What about aggregate data on research and development, both public and private, which is not probably available now? Should that also become available? So one of the key questions really within this health union package is, how do you make sure you have good data for policy making, and how do you make sure that member states, they actually report these data in a standardized manner? And how do you ensure that they comply with the data reporting, rather than just having incentives from the ECDC saying, yeah, you could have your portion from the, what is it called? Health for, what is that called? The health budget. It just escapes me now. Health.
The EU for health?
Yeah, the EU for health, yeah, exactly. That you could have an extra chunk of money from that budget if you fulfill your reporting requirements. I mean, is there other ways that we can ensure member states, they really fulfill them?
You're absolutely right, Maja. I mean, I also come back to a key point, or rather two. One of them, that some of these questions are questions that we can't sort of just postpone indefinitely, that they are finding solutions on their own sort of, either in the market or by other actors. But there's a specific question in the chat, I suppose, to you, Bogi, since you, I think, answered part of it, about the ERNs. Earlier, Anniek mentioned these as a sort of a role model for something that has really made a difference, but yet they make a difference if they have the data available to them also. So, Bogi, how, for instance, when we see in practice that sometimes UK experts get excluded from some of the research labs on these rare diseases or not rare diseases, we need the health data to be able to do the research that helps us with all kinds of diseases, I suppose.
Yes. So I think let's let me try to answer this in 2 or 3 stages. So one thing is the first stage of the European Reference Network, which is an expert collaboration, which is trying to standardize care across Europe in certain disease. So that part is not doesn't really have an interface towards the patient. It has an interface between experts in that way. And is that better than not doing it? Yes. Is that good enough? No. So to me, what we need to work with on this part, having in mind that we have some rare diseases, we have not so much on communicable diseases apart from the pandemic that we have now, and then we have a lot of behavioral aspects of disease. But even in this chronic diseases, behavior as a secondary prevention is extremely important. And if we are not including the person and having the person getting data back on what is good for me, and that is fed back to the system on how is my holistic treatment situation, we are actually not using the potential of data. So the setup we have today is an interclinic setup of data and standard. It's not a holistic what helps the individual person set of data. That's what we have, which Lars and me also have worked a lot with in the Nordic health movement. How do we work with that going forward? The question to me is very much also on how do we create societal value with health? So if there is a burden on society with disease, then what is the value with health? So thinking it reversed in that way. And I'm fully in on that legal questions will not solve the issue. I'm a political scientist, so we used to say at the Friday bar to the lawyers that the law is just frozen politics, which it is in certain way, even if it's not that part. But going back to, if we now are being smart and thinking, what has increased health and life conditions the last 150 years in Europe? That's not hospitals. It's clean waters, it's schooling, it's better life conditions, better living conditions, less road accidents, less violence, even refrigerators, affordable for middle class, is a huge impact where you see them coming in. So we should also think, as Anniek also was saying, on what is it that provides health, which is not just the health budget in that way. So, and that comes back to social determinants of health in a more advanced way. How can we work with that? How do we work with a One Health approach? So my approach to working with these kinds of things is also saying, when we have the discussion on is the environmental challenge, the climate change, is that the biggest health threat we have? No, it's not. Bad health conditions is the biggest threat that we can work with climate change, because we don't have the bandwidth outside of the richest countries. So sometimes we also need to think about what is the correlation to what gives the good life conditions and the good health. And coming back to the questions on how do we then get the connection between the individual person and something like the European Reference Network, and that is having the person access to data and having the person producing data themselves will be used. And will we have a lot of challenges working with it? Yes, because we will work with unstructured data, external data that we need to validate in different ways. Yes, but that's the way it, in my opinion, needs to go forward.
Interesting. But being mindful of the fact that we are slowly running out of time for this session, and without, if you will forgive me, but painting you three as a sort of we have here a legal argument, a democratic argument, we have a financial, practical, and we have an ethical, and you can choose, the three of you, which ones I'm thinking of, but maybe if we're looking for the immediate future, what sort of the things that you would really like to see, perhaps in the later stages of 2021 or in 2022? How do we move a step or two closer to either A, European Health Union, or B, some questions to some of these burning problems that we actually have had or are still sort of experiencing? So please, Anniek, if you start perhaps with what sort of two, three key elements that you would like to see in the immediate future.
Well, I mean, I'm still processing that law is just frozen politics comments. I'm digesting, but
you can use it in a drink then. That's nice.
Yes. So I think that health is a political issue, right? Health is about ethics. Health is about stuff that is very personal, but also where the personal becomes very political, because we're all, national elections, they are often in large part about health, about access to health, about what is the government doing for us to be healthy, safe. And so I think that the EU in this respect has had a very technical approach to this. So standard setting on food safety and all of this, actually issues that are quite political themselves, but they're always packaged up as something that is rather technical. And what I would want for the future, and if law can help in doing that, then I hope it can do so, is to make the discussion on the EU's involvement in health, which is huge, right? The safety of food, markets, trades, all of these things are hugely important for health. To make the discussion on health more political, more legitimate, invite more actors, more participatory. And so I think that to bring politics, to bring health politics to the EU is one of my wishes for the future. And I think law should be there to enable that discussion to take place in the EU.
Thank you, Anniek. A brief comment from you then, Maja. Your Christmas wish.
My Christmas wish?
Yes, there's a long time to Christmas, but still they have time to make it then. And in Father Christmas's elves in the North Pole, perhaps.
And the EU is busy as well, because the Commission just 2 days ago came up with the document of early lessons learned. And the idea is to have the current health union proposals being finally negotiated by the end of this year. Of course, that's just the first step. But for that, maybe it gets finalized in December, just for Christmas. I would like to see a better data sharing between member states, particularly to the Commission and the ECDC, and also much greater coordination. And for my New Year's resolution would be that we managed to get something similar to BARDA in Europe. We managed to pool our resources when it comes to getting a unified approach to invest in R&D, be it vaccines or other critical medicines or antibiotics. So I guess I'm the one with the financial hat on from your presentation. But just one last comment, perhaps when we look at this European health package, I mean, that is being discussed amongst health ministers. So maybe this is the moment where the health community is more involved than they have been before.
And you, Bogi? It doesn't have to be a Christmas wish.
No. So my wish is that we can get a understanding that health is investment and not a cost, and get that dynamic in. Go back to Anniek's point on what provides health? So can we get a health and all policy where we actually think about providing health in everything else that we do? So do health on the go, not necessarily do health in the health space. So if we can get that understanding in as a dynamic working to the future, I will behave on my Christmas meal and eat healthy.
Coming from someone from the Faroe Islands, that's a tall order too. But still, thank you very much, all three of you, for joining this debate. There was a fine point about the ERN in the chat about that such problems are actually what happens when health stakeholders not at the table. And that's perhaps what we should bring forward, how to do, regardless of how we do it, by frozen politics or otherwise. How can we bring health stakeholders to the table in the future so that we ensure that we solve some of these problems in the best way possible for us all? Thank you very much for joining, and hope to see you soon in some other virtual space.